this is a complex arena here now in which perhaps people are picking up various batons to try and streamline. But when you think about any groups of measures or categories or types of measures that you think we could begin to let go of in favor of something else, could you speak to that a little bit more? Where might we go with this?
I think that the one of my premises is a little more forceful, which is to set a limit. I think that we have I call it intemperate measurement now, which is as bad as intemperate healthcare, because there's never been a budget. That no one's ever said we'll allow ourselves the following amount. And so what we've had is more and more and more and more. And it's insane right now. It really is. It's driving people out of their, away from patients, I guess is the best way to say it. So I'm making a rather arbitrary argument. Let's set a goal here. And I do put the goal in the ground. 3 out of 4 mandated measurements that we currently use should go away. We should commit to it. I say within the next, I'd say cut them in half in 3 years and half again in 5, but even that's slow for me. So I say without that kind of discipline, we're not going to do this. We're just going to keep eating away at edges without changing the fundamental dynamics. If we did that and we said, hey, we got a problem now, we have a budget, it's 3 out of 4 of the mandated measurements we use now have got to go away, what are we going to do? Well, let's start to make a list. Redundant metrics, which are close to the same thing but not quite the same thing, stop it. And that's, I'm happy to see what AHIP and the America's Health Insurance Plans and CMS have done. They said we're going to try to stop being different when we're trying to measure the same thing. That's good. I think that Porter and Lee's argument about moving toward outcome is a good discipline. If we said if it's not an outcome measure, it's got to bear a lot more burden before we actually use it. That would be good. I think there are micro-process measures which it's tick-the-box stuff. Yes, we measured this or we tested that. I don't really think those help. The people that disagree with me say, oh, look, when you start to measure it, people do it. I say that's the problem. You actually create compliant, tick-the-box behaviors, not just measures. So I actually think this is a great task for America to take on over a 6-month period. Maybe the National Quality Forum could help us. But you get a budget. You take away 3 out of 4. That's the requirement. Now, what's the rule base on which we could go ahead and do that? I would posit, by the way, that if we did it, not a hair in anyone's head would be hurt, except maybe the measurement industry. And we would end up with more valuable and more usable stuff.
Anyone on the program who's listening, if you have some thoughts on that as well, feel free to chime in the chat about some of the measures that you might see are not adding so much value. Don?
Yeah, a chat just came in from Jacqueline Poppin. That's a very important point. There is a developing sector in the measurement movement toward PREMs and PROMs, patient-reported experience measures, patient-reported outcome measures. These, of course, they have a long history, but they're actually being brought now to a pretty good form. And the OECD has an advisory group that I serve on, which is recommending to OECD nations that at the national metric level, they begin to use PREMs and PROMs as the core. And that makes some sense to me. If I really could only measure one thing, I think I'd do what Jessica did. I'd go ask the patient, say, how's it going? And any way we can get that going, I think will help us navigate toward quality.